about the newest guidelines in the context of single pill combination approach, focusing especially on the combination with ACE inhibitor and beta blocker. What is the rationale behind it? Of course, I will try to present you the newest findings, the newest data. We are at the dawn of the preparation for the 2013 guidelines. We just started to work on the new version of the guidelines. But before I talk about the newest trials, the newest recommendations, let me take you to prehistory. Long time ago, year 1981, so more than 40 years ago. If somebody would ask a question, yes, that's me entering the medical university of guys. You can see a shy student, not certain about the future, what would happen then. I feel still, I'll say, young in general, although I'm already a grandfather. But the progress we witnessed is enormous. So if we go to 1981, this is what I remember from physiology classes at that time. Everyone was talking about the sympathetic nervous system. We knew that this system is very important for development of hypertension, but also cardiovascular disease in general. We started to discover more about the role of renin, angiotensin, aldosterone system. So those two systems, they play the role of the bad and the ugly for development of cardiovascular disease. And at that time, we thought, what would be the protective factor for cardiovascular disease? And we knew already there's something in the vessels. In the interior wall of the vessels, there was something at that time which was called endothelial-derived relaxing factor. Later on, it turned out to be nitric oxide, as we all know. If we would consider those two systems, they create a kind of positive loop. So the activation of the sympathetic nervous system would release renin, which will start the whole cascade of the system. On the other hand, angiotensin 2 would increase the sympathetic drive at the level of the periphery, but also at the level of the central nervous system. So let's go very briefly to the concepts in the 80s, a while ago, but quite interesting what we have learned. So at that time, everyone was talking about disease-specific drugs. So beta blockers, at that time we knew they were useful for hypertension. Digitalis was the main drug for heart failure, nitrites for coronary artery disease. If you had myocardial infarction, you had to stay in a bed for 4 or 5 weeks. Then if we would consider beta blockers, they were contraindicated in heart failure and post-MI. Then the future of ACE inhibitor was unclear. There was a lack of randomized clinical trials at the time when I was a student. And most of our professors told us, avoid combination treatment. Start with one drug, increase the dose, then go to the maximum dose of the drug. So if we would go to the history of development of cardiovascular therapy, in the year 1981, actually the FDA approved the captopril as the first drug for management of hypertension. Despite the true lack of the evidence, we didn't have large randomized clinical trials for ACE inhibitor, but it was enormous progress. This drug worked beautifully. Of course, the main problem with this drug was that it had to be used 3 times a day. Later on, some progress with enalapril, but this was the very beginning of the ACE inhibitors. Later on, the class of ACE inhibitors changed cardiovascular management in general. Not only hypertension, but heart failure, coronary heart disease. They are useful also in patients with atrial fibrillation, patients with chronic kidney disease, and so on. The list is very, very, very long. And when the newer class of drug blocking renin-angiotensin aldosterone system arrived, the ARBs, Some people said, well, we have finally ACE inhibitor without any side effect in terms of the cough. But the truth is, if we go to randomized clinical trials, and now I'm talking about the trials performed from the beginning of the 80s till now, if we would consider what would be the impact of RAS blockade on all-cause mortality, and this is the hardest endpoint that you can imagine, also relatively easy to assess. You can see on the left the impact of ACE inhibitors, on the right the ARBs on total mortality. And you can see while ACE inhibitors reduce significantly the risk of total mortality, there is no evidence that with ARBs you would achieve such effects. So no way to say they are comparable or they are exactly the same in terms of at least prevention of total mortality. If we would consider the trials, most important trials showing the benefit, actually those trials were performed with perindopril. The ASCO trial, the ADVANCE trial, the HIVE trial were based on perindopril. I will come to more details in a moment. Already in 2013 in the guidelines, there were many additional indications to use ACE inhibitors. So patients with left ventricular hypertrophy, asymptomatic atherosclerosis, microalbuminuria, renal function, previous MI, angina, heart failure, proteinuria, peripheral arteries. You can see the list was very, very long, including metabolic syndrome and diabetes mellitus. So why to consider combining a beta blocker with ACE inhibitor? I said that perindopril was tested in various clinical conditions in hypertension and the ASCO trial, in the ADVANCE in patients with diabetes and post-stroke patients, and the list is extremely long for this drug. But another very important trial, landmark trial performed with perindopril, was a Europa trial, which completely changed the way we manage coronary heart disease. We know not only heart failure, but in patients with coronary heart disease, the ACE inhibitor is a must to use. And in the Europa trial, there were some patients who were treated with both a perindopril and a beta blocker. And you can see that while for primary endpoint, but also for non-fatal myocardial infarction, the greatest reduction of risk was observed in those patients who were on both perindopril and beta blockers. It's a very strong rationale coming from the Europa trial that you should combine ACE inhibitor and beta blocker. It might provide benefit. We know that many of our patients have comorbidities and not only coronary heart disease, but heart failure and so on. And within the group of patients with coronary heart disease, most of them they have history of hypertension. So this was the rationale to introduce fixed dose combination of bisoprolol and perindopril, and I have to say that Poland was one of the two first countries to use this drug all over the world. So we have already several years of experience. So bisoprolol, very cardio-selective beta blocker, no intrinsic symptomatic activity, very safe in terms of glucose metabolism and lipids. A very important issue, long-lasting effect. This is what we would like to achieve in terms of the protection, cardiovascular protection. And perindopril, so very well studied drug in terms of the clinical trials with a huge tissue selectivity. Of course, you get the blockade of the renin system, but then you get also the increased bradykinin effect, which explains a significant proportion of the benefit observed, especially in the setting of coronary artery disease. This drug has also very long-lasting effects. So what you get, you have three things at the same time. So you get cardio protection, you get much better blood pressure control because you block two mechanisms, and if you think about a fixed dose combination, you improve the compliance. So if I would describe this combination, so a very long-lasting ACE inhibitor covering day and night, and the same for a beta blocker allowing the use of fixed combination once a day. So if you go to the current guidelines, the 2018 European guidelines, and I had the privilege to contribute to this document, I mentioned that we started to work on the newer version of the guidelines, which we probably release next year. But in general, this is what I'll say about fixed combination, about ACE and beta blocker should remain the same. So many things already changed in the 2018 guidelines. I know that you are aware with this document. It was very well perceived, not only in Europe, but all over the world. So we kept the same definition. We didn't accept the American recommendations. We believe that 140 over 90, this is the right definition of hypertension. We didn't accept 130 over 80. Let's focus on those who've true hypertension above 140 over 90. We have lower target blood pressure. I will come back to this in a moment, because the previous guidelines from 2013, they said go below 140. But many physicians ask, how much below? 138 would it be enough, or maybe 130, maybe 110, or even 105, because it's still below 140. So it was not precise. With the new current guidelines, we say first go to 140. This is the first step, but then go below 140. It's actually 130 is a new target for systolic blood pressure. But importantly, in people who are younger than 65, if you achieve 130, you should go lower. You should go lower than 130, but not lower than 120. So the optimal range for somebody younger than 65 will be between 120 and 130. And this would include also, for example, patients with diabetes. So in general, this is the scheme of the guidelines. So in grade 2 and grade 3, and in general, we should try to aim for blood pressure control within 3 months. So let's say if we start now in November, your patient should have the blood pressure control already in February next year. Of course, we need good drugs. We also need patients who are compliant, but we should also avoid inertia from our side. And I would say we should be really proactive in our patients. There are different phases of inertia. It might be diagnostics. You fail to diagnose hypertension or to reveal uncontrolled treated hypertension. Your patient is on drugs and you say, well, the patient is controlled, but in real life, the blood pressure is above the target. It might be therapeutic. You might fail to initiate or escalate treatment. I would add to this also failure to choose the best available treatment. We should really go for those drugs which have the evidence based behind it, so the randomized clinical trials. A very important component of a success recipe for somebody with hypertension will be also patient adherence. It's a very important study which somehow opened the eyes of the hypertension community, trying to see what is the risk of non-adherence according to the number of pills. And you can see if the patient is on 4 or more drugs, or even on 3 or more tablets, the risk is of compliance, poor compliance, or this partially poor compliance high. But if the patient is on 1 or 2 drugs, the risk is much smaller. So the patients in real life, they prefer to take one pill. Then the combination therapy and single pill approach. This is the biggest change in the guidelines. So the strategy that was a kind of revolution in the management of hypertension that we introduced. We say that we should prefer the use of 2-drug combination even for the initial treatment. So at the very beginning of treatment, we should prefer a single pill approach, not giving 2 separate tablets. And we simplify the drug treatment algorithm, the algorithm that you know. Why we insisted so much on fixed dose combination? It's very simple. You get better and faster blood pressure control. Very importantly, you have less variability in response. If you give combination therapy of 2 drugs, actually all of our patients will have some drop in blood pressure, with the exception of those with secondary hypertension, of course, with the exception of those who are not compliant. It is safer and better tolerated than monotherapy. In a high dose, you have the better adherence to therapy, and with 2 simple treatment steps, you might control blood pressure in more than 80% of your patients. Very importantly, we have the evidence that if you start with a combination therapy, with a fixed dose combination treatment, you observe a greater reduction of cardiovascular risk. This is a very important study coming from Italy, from the group of Professor Mancia, trying to see, to compare those starting with monotherapy, those starting with a fixed dose combination for various endpoints. You can see if you, from the very beginning, start right with appropriate combination, there's a much greater reduction for cardiovascular events. You might have heard some rumors that beta blockers are dead, that they should not be used in hypertension, but this is not true. First of all, the guidelines, for the very first time, they recognize the role of stress, and also they put in the tables faster heart rate, faster than 80 beats per minute as risk factors. This is for the very, very first time. And beta blockers are used among the first-line treatment. At first glance, when you see this algorithm, it will tell you that you should focus on a drug blocking renin-angiotensin system with a calcium channel blocker or a diuretic. But the same figure, don't forget that they say with the beta blockers, we must use beta blocker when there's a specific indication like heart failure, angina, post-MI, atrial fibrillation, and so on. So also for the other guidelines, coronary heart disease, heart failure, and so on, they recognize the position of the leading position of ACE inhibitor and beta blocker. If you combine those 2 drugs in a single pill tablet, you have this 24-hour coverage, but you also improve blood pressure control compared to use of ACE inhibitor alone. This is a meta-analysis of several studies, not only this time in Europe, but also advanced progress trials, to see what would be the beneficial effect of combination of perindopril with beta blocker in almost 30,000 patients randomized to those trials. And you can see not only in the Europa trial, but also in other trials, including only hypertensive population, was a very dramatic decrease in the risk for primary endpoint, for myocardial infarction, but also very importantly for all-cause mortality, which was reduced by almost one-third. So let's go to the use of beta blockers in a clinical practice in my country, in Poland. I mentioned that combination of ACE and of perindopril and bisoprolol is already in Poland for several years. And we try to understand what are the trends of beta blockers use in Poland. So first of all, they are widely used in different subgroups, mostly in a combination therapy. Of course, the older your patient, the greater probability of using a beta blocker. But overall, more than half of Polish patients, they were on a beta blocker, and bisoprolol was the most popular one. Of course, the indications to use a beta blocker are different in younger than in older patients. In older patients would be primarily classical indications like previous MI, heart failure, coronary heart disease, arrhythmias including atrial fibrillation, while in younger patients will be primarily hyperkinetic state, sympathetic activation, and faster heart rate. So I'll come back to the story of heart rate, of this 80 beats per minute, referring to a very important study from, again, from Italy. So they try within the population of patients with hypertension to compare those with 80 beats per minute and less than 80 beats per minute. And first of all, they saw that there's a quite close correlation between this, what you observe in the office, with this, what you observe with microneurography. So this MSNA, signals sent from the brain to your vessels. It's also a good correlation between the heart rate in the office, also 24-hour heart rate. So if you see your patient in the office with faster heart rate, it's also very likely to have tachycardia out of the office. Importantly, the faster the heart rate, the greater the risk of target organ damage, including left ventricle hypertrophy. So the editorial accompanying this original paper suggested that in people with hypertension, even without those classical conditions like heart failure, myocardial infarction, and so on, if you see younger, especially younger patients with 80 beats per minute or more, it means this patient has higher sympathetic activation, has higher cardiovascular risk, and we should consider beta blockers also in a setting of patients without complicated hypertension. This was highlighted further in a very important editorial or review published a few months ago in Hypertension. You see the names of, again, Professor Mancha, who was the president of the European Society of Hypertension, also the chairman of the writing committee, but also other very important key opinion leaders. Ferenc Jelsin, past president, Reinhold Kreuz, past president, Mari Essler, who is very well recognized all over the world in terms of the sympathetic nervous system, and Guido Grassi, who is actually the current president of the European Society of Hypertension. So this document somehow summarized the position of beta blockers, making an argument that actually the indications are much, much wider than this what was suggested by the previous version of the guidelines. So you have, the recommendations, the compelling indications I told you, like angina, post-MI, heart failure, but also faster heart rate and atrial fibrillation. Don't forget about aortic dissection. You also would like in those patients with slower heart rate. But the list of other cardiac indication is actually much, much longer. So in many of our patients, we use the list is here that you would consider a beta blocker into patients post interventions related to coronary artery disease, and several other indications, including obstructive sleep apnea is a very, very good choice. We use beta blockers in pregnancy, in portal hypertension. Some guidelines recommended also as a part of non-cardiac surgery with the excessive response to stress or exercise, and so on. Several other indications like the diseases of thyroid, the migraines, the essential tremor, glaucoma, performance anxiety, and anxiety disorders, and so on, including post-traumatic stress. On the top of this, I would add also post-COVID, long COVID, because those patients with long COVID have also activation of the sympathetic nervous system. So the list for compelling indications is really, really very, very long. In Poland, but also all over the world, I see some patients saying, well, does it make really a difference to use a fixed dose combination, two drugs in one tablet, or giving it separately? And I say, well, of course it does, because consider that your patient would be treated for years, for decades. And of course, if you go on your summer vacation and you have time and there's a beautiful setting, maybe if you rent a car, you would like to have a car with manual transmission to get this feeling that you control the drive. But for daily use, if you go every day to the hospital and you are stuck in the morning traffic, for sure we would like to go to automatic transmission. And this is the beauty of a single combination. It's much easier for your patient to develop a habit, and for compliance you must develop a habit. And it's much easier to develop a habit with one tablet, a single combination approach. You take one pill in the morning with your coffee, tea, whatever. So the question is, ACE inhibitors and beta blockers in somebody in a single pill, for whom it might be considered. For sure, for post-MI, for sure in patients with hypertension, coronary artery disease, and as I said, those with elevated heart rate. And I would argue that even in younger patients with hypertension, those with faster heart rate, and in people who are younger, 1/3 of your males, or even more, 40% will have faster heart rate. So in younger male with faster heart rate, I think this is also the best combination. You get the benefit of blocking the renin-angiotensin system, but also you block the sympathetic nervous system. So let's go now to the clinical case, because I count on any questions or discussion afterwards, but let's go to a clinical case. A 60-year-old male with hypertension, diagnosed a long time ago. Previous treatment including ACE inhibitor, ramipril, which is still a popular ACE inhibitor, and amlodipine, given separately. Amlodipine was given once a day, ramipril as well. Other comorbidities included dyslipidemia. Patient was treated with simvastatin, which at the moment might be questioned as the best way to manage dyslipidemia, with impaired glucose tolerance treated with metformin. He put on some weight during the pandemic. He's a previous smoker with a positive family history for both hypertension and cardiovascular disease. His current complaints include atypical chest pain. As you can see, this patient is overweight with increased waist circumference, with faster heart rate at baseline. His office blood pressure is elevated. It's the average of several measurements of 144/88. His ECG shows no sign of ischemia. He's in sinus rhythm, but with faster heart rate. With echocardiography, the patient shows the left ventricular hypertrophy with the enlarged left atrium. Ejection fraction is normal, but there are signs of diastolic dysfunction. The patient underwent 24-hour blood pressure monitoring, and you can see that his blood pressure was 138/86 during daytime and 130/78 during nighttime. We remember that for ABPM we have other cutoff points. We would like to have blood pressure during daytime below 135/85, so it is here too high. But especially for night, 120/75 would be ideal blood pressure control, and this is here highly elevated, which might be the effect of the use of ramipril, which is a relatively short-lasting ACE inhibitor. It will not cover 24 hours like perindopril. So otherwise, this is the lab with increased hemoglobin A1C. The LDL is too high, so we should change the statin treatment. Fortunately, GFR was normal and there were no signs of hyperkalemia. So atypical chest pain, and what we would do in Europe, of course, we try to follow the European guidelines, and the current document is the recommendation from 2019 for the diagnosis and management of chronic coronary syndrome. So this is a new name of something what in the past we used to call stable angina. So chronic coronary artery syndromes, which includes all forms of coronary syndromes other than acute coronary syndromes. So you must ask a question, because the symptoms shown by these patients were not the three typical, rather atypical. What is the probability of a significant coronary artery disease in this patient before you decide which would be the optimal diagnostic test and what would be the best treatment for this patient? So this is a man which probably because of the age, other risk factors, the probability is around 26% of coronary artery disease. So what the guidelines tell us? In the past, we went rather for either some people would go for invasive angiography, some people would go for the other tests. But at the moment, the guidelines recommend coronary CT angiography as the best way in those patients with atypical chest pain. So if you consider all the steps, so first of all, the symptoms is unstable angina. Think about heart failure, so ejection fraction here was normal. Think about other causes, we're not able to identify the cause. So this patient would be a candidate to assess the likelihood of obstructive coronary artery disease. So coronary CTA, angiography is preferentially considered if you have relatively low clinical likelihood in this patient, so it's around 25%. This is a patient who is overweight but not obese, which suggests might have good quality of the CT scan. And then in many European centers, including my hospital, we have really experts in those patients. And of course, we should not perform this test in those who have already a history of coronary artery disease, but this patient had no coronary artery disease history. So we might skip coronary CTA, go immediately to invasive coronary angio when you have high clinical likelihood and typical symptoms of angina, when you have the signs of dysfunction. So then you might go immediately to invasive. But in our patients, we decided to consider the coronary CTA, and the outcome of this test was that there were multiple plaques, but the stenosis was up to 30%, which was rated in a right coronary vessel, and the Agassiz score was around 160, showing that indeed we might talk about coronary artery disease, but because of the type of the plaques, though, are really obstructive stenosis in terms of more than 70–80%. This patient will be a candidate for the non-invasive treatment, rather drug therapy. So what we did in our patient, the patient was previously treated with ramipril. We changed to perindopril, the best drug for a patient with coronary artery disease among ACE inhibitors. We added beta blocker because now it's a very compelling indication to use a beta blocker because of the coronary artery disease, bisoprolol with many advantages I already mentioned. And of course, we decided to go to a single pill combination immediately. This is a way to simplify the treatment. And the patient now would require acetic acid aspirin because of the coronary artery disease. Furthermore, the patient should intensify the lipid lowering, going from simvastatin, we went to rosuvastatin, because now we have a much more ambitious target for LDL. Some lifestyle changes are also required, and we should be quite careful about the risk for development of diabetes. So in summary, I would say that this fixed combination coming now to your market of bisoprolol and perindopril is supported by the guidelines. This was the first in the market with the already very good experience in many countries. I know that also in some other countries in your region, like Tunisia and some other countries, this combination is becoming widely used. Importantly, it is supported by evidence-based medicine. It has long-lasting components of both bisoprolol and perindopril. Bisoprolol, the most widely used beta blocker all over the world. It's fulfilling your expectations because you have the best drug in one tablet, but also fulfills the expectation of your patient. The patient would like to be treated in a simple manner. So this would be the best way to use those widely used components with evidence-based in a single pill combination approach. Thank you very much for your attention.